Understanding and treating weight loss in pancreatic cancer. Hello, this evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon. And if you or someone you care about has been diagnosed with pancreatic cancer and you're noticing concerning weight loss or muscle wasting, you're in the right place. I know watching someone you love lose weight rapidly can be incredibly frightening, and if you're going through it yourself, it's both physically exhausting and emotionally overwhelming. But today we're going to understand exactly what's happening in your body and what can actually be done about it. By the end, you'll understand why this isn't about simply eating more, what the real underlying mechanisms are, and know exactly what interventions can make a genuine difference. Before we dive into the specifics, let's quickly establish what we're dealing with. Cachexia. That's an accelerated loss of skeletal muscle in the context of a chronic inflammatory response. Now, what does this look like in real terms? This isn't the typical weight loss you might see with dieting or reduced appetite alone. We're talking about your body actively breaking down muscle tissue at an accelerated rate, even when you're trying to eat. This matters to you personally because it affects your strength, your ability to tolerate treatment, your quality of life, and ultimately your outcomes. This is one of the most common and challenging complications of pancreatic cancer, but understanding it is the first step to managing it effectively. Cancer-related cachexia occurs in up to 80% of patients with pancreatic cancer, particularly those with metastatic disease. That's 4 out of every 5 patients. You can do the math right. If you're experiencing this, you're absolutely not alone, and this is not because you're not trying hard enough to eat. The data reveals that this is a complex metabolic syndrome driven by the cancer itself. Now, you might be wondering what makes pancreatic cancer so different. Here's where it gets interesting. Pancreatic cancer uniquely attacks your body's ability to process nutrients in multiple ways simultaneously. If you're supporting someone through this, understanding that this isn't about willpower or appetite alone is crucial. This is biology working against the body in very specific ways. Let me explain what's actually happening inside your body. Contributing factors include inappropriately accelerated resting energy expenditure. That means your body is burning calories faster than it should even when you're resting. But here's the critical part. We're seeing alterations in nutrient metabolism, specifically increased protein breakdown. Your body is actively catabolizing, breaking down muscle protein to use as fuel, even when you're consuming adequate calories. Now, what does this look like in real terms? Imagine your body as a house that's burning its own structural beams for heat, rather than using the firewood you're providing. That's essentially what's happening at the cellular level. The chronic inflammatory response created by the cancer drives this accelerated muscle breakdown. This is why simply increasing calories or protein intake doesn't fully solve the problem. We're dealing with a fundamental metabolic derangement caused by the cancer. Here's something that might surprise you. A major contributory factor to the extreme weight loss often seen in pancreatic cancer is pancreatic exocrine insufficiency. This leads to maldigestion, fat malabsorption, and steatorrhea. That's fatty, difficult-to-flush stools. The available evidence suggests that pancreatic enzyme insufficiency is remarkably common, affecting 64 to 100% of patients with pancreatic cancer, even those who haven't had surgery. Now, what about the practical impact? Fat malabsorption doesn't become evident until lipase secretion. That's the enzyme that breaks down fat, is less than 10% of normal levels. Pancreatic enzyme insufficiency causes nonspecific symptoms, such as abdominal cramping, flatulence, urgency to defecate, and weight loss. The typical characteristics of fatty stools may not even be evident, because patients tend to limit fat ingestion instinctively. As a result, the main clinical manifestation is malnutrition and profound weight loss. This is when addressing pancreatic enzyme insufficiency becomes crucial. The tumor can compress or obstruct the main pancreatic duct after surgery, after radiation, or simply from tumor growth. We're not talking about extreme pancreatic failure here. Even partial obstruction significantly impairs your ability to digest and absorb the nutrients you're eating. Anorexia, that's loss of appetite or reduced caloric intake, commonly accompanies cachexia, but they're not the same thing. Anorexia involves reduced oral intake, while cachexia involves accelerated muscle breakdown even when intake is adequate. However, in pancreatic cancer, both typically occur together, creating a devastating combination. If you're worried about someone you love who's losing their appetite, here's what matters most. Up to 60% of patients with pancreatic cancer have slowed gastric emptying without evidence of tumor invasion into the stomach or duodenum. A possible explanation is tumor infiltration into the nerve plexuses controlling digestion. This invariably leads to anorexia, and in approximately 1/3 of patients, significant nausea and vomiting are present. These concerns are completely normal and understandable. When you see someone struggling to eat even small amounts, it's natural to feel scared. But understanding that this is a neurological and mechanical problem, not just not feeling hungry, helps frame appropriate interventions. Let me connect all these pieces. Cachexia is fundamentally an accelerated loss of skeletal muscle in the context of a chronic inflammatory response. The cancer itself creates this inflammatory state, releasing cytokines, signaling molecules that fundamentally alter how your body processes energy and protein. Now, what does this mean for your daily life? This inflammatory response increases your resting energy expenditure. You're burning more calories just existing, while simultaneously breaking down muscle protein and reducing your appetite. It's a triple hit: burning more, breaking down what you have, and making it harder to replace what's lost. That's why cachexia is so much more than simple malnutrition or starvation. It's a complex metabolic syndrome. If you already have advanced pancreatic cancer, here's what matters most. Recognizing that cachexia is an active process driven by the cancer, not a passive consequence of reduced intake. This understanding shifts our approach from simply eat more to addressing the underlying metabolic derangements and providing targeted nutritional support. First consultation with nutrition specialists is essential. All patients with locally advanced or metastatic pancreatic cancer should consult with a nutritionist and/or dietitian if this service is available. Dietary intake should be assessed along with the possible need for dietary supplements. This isn't optional. This is a core component of your care plan. Second, pancreatic enzyme replacement therapy. Given the high incidence of pancreatic enzyme insufficiency, patients who are suspected of having fat malabsorption should be treated empirically with oral pancreatic enzyme replacement. Now here's the specific dosing. 30,000 international units of pancreatic lipase swallowed during each full meal should suffice in reducing steatorrhea and preventing weight loss. 1/2 of that dose, 15,000 international units, should be administered with snacks. Let me make this practical. These formulations are typically measured in USP units in the United States. 30,000 international units equals approximately 90,000 USP units. Patients should be instructed to take enzyme supplementation at the start, at the middle, and near the end of a meal. Patient compliance is absolutely critical to the success of therapy. Skipping doses dramatically reduces effectiveness. Third, dietary modification, but not what you might think. Classically, patients with pancreatic insufficiency were told to restrict fat intake to reduce steatorrhea. However, this approach restricts intake of fat-soluble vitamins, which are already malabsorbed. The available data suggests that enzyme activity within the small bowel is actually enhanced by the presence of fat. For all these reasons, severe fat restriction should no longer be considered the rule. Instead, frequent meals of low volume and avoidance of foods that are difficult to digest, think legumes, raw vegetables, are generally recommended. Pharmacologic management of cachexia. Additional pharmacologic management of cancer-associated cachexia syndrome exists beyond enzyme replacement and dietary modification. Your oncologist should discuss options for appetite stimulants and anti-inflammatory approaches that may help address the underlying metabolic derangements. Addressing gastric emptying issues. If you're experiencing significant nausea, early satiety, or vomiting, discuss whether delayed gastric emptying might be contributing. Prokinetic agents such as metoclopramide may help. For persistent symptoms, interventions like venting gastrostomy tubes or combined gastrostomy-jejunostomy tubes can both palliate symptoms and provide nutritional support during active therapy. Sample questions to ask. Am I a candidate for pancreatic enzyme replacement, and what specific dosing should I use? Could delayed gastric emptying be contributing to my symptoms? What pharmacologic options exist for managing cachexia beyond nutrition? Should I be taking acid suppression medication to help pancreatic enzymes work better? Monitoring response to intervention. Determining adequate enzyme dosing requires monitoring. If steatorrhea persists despite enzyme replacement underdosing acidic intestinal pH, the enteric-coated tablets require a pH greater than 5 for enzymes to be released, or intestinal bacterial overgrowth may be hindering response. Consideration should be given to inhibition of gastric acid secretion with proton pump inhibitors. Severe persistent vomiting. This may indicate gastric outlet obstruction or severe gastroparesis, requiring urgent intervention with decompression strategies. Inability to maintain any oral intake for more than 48 hours. This requires urgent evaluation for alternative nutritional support strategies. Rapid weight loss exceeding 10% of body weight over 2 to 4 weeks despite interventions. This suggests cachexia is progressing despite current management and requires reassessment of your treatment approach. Let me quickly recap. Cancer cachexia in pancreatic cancer is a complex metabolic syndrome affecting up to 80% of patients driven by accelerated muscle breakdown, pancreatic enzyme insufficiency, and chronic inflammation, not simple malnutrition. Your next step: schedule consultation with a nutritionist and discuss starting pancreatic enzyme replacement therapy with specific dosing of 30,000 international units with meals. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.